Now, want to get my screen up. There we go. Does that work for you all now?
Yes.
Oh, yes.
Yes.
Great. Well, Nancy, thank you very much for asking me to speak on a topic that I didn't realize I first introduced you to, but it is a topic that I have followed for over a decade and was involved in the first palliative care clinic offered at Carillion. I am not a lead provider now, but I have reached out to two of the services that I know are highly respected and are very that are regular participants in providing palliative care to make sure I'm updated. So hopefully I'll leave you some information on slides, and certainly there's time for questions. So Deborah, if you control it, I can't click the slides the way I'm used to doing it.
Okay. You could just tap on it. No, there you go.
There we go. Now I can.
Yeah.
Okay. Let's see, are you all seeing the full slide?
I guess it
Yes.
starts with Second
I've got the
Presbyterian Church.
Yeah, I've got the side. I wonder if I should do I'm on normal view. Don't you think that's right?
Yes.
Okay. So here, we've already talked about the first thing that, a long-term church member here. And many of you have heard me speak before, whether it was on memory or whether it was on normal aging or whether it was on caregiving. But I'm pleased to be here and pleased that Nancy has been so smart to get you together during this COVID year, and that you've learned how to do Zoom and you've kept up with each other. That's so important. The isolation that people have experienced this year is very tragic. And so anything that we've done as a church or through Dr. Morris is certainly a wonderful thing. So let me I'm going to get more informal after about 4 slides, but I want to make sure I start from, a lit review, a normal little basic education here. And one of the questions that comes to me is, why is palliative care so important all of a sudden? And I think it's really because palliative care is becoming more and more a type of practice, a type of intense medical service that is now available, and it's so helpful. And so what we know in the literature from a large study is that early integration of palliative care reduces depression, reduces symptom burden, and improves quality of life. So what is symptom burden? Well, it's basically the most distressing symptoms that you tend to think of with the diagnosis or plural diagnoses that you carry. So for people with lung cancer, we think of breathlessness, pain, fatigue, anorexia. All of these are typical symptoms of people with a bad lung cancer. With congestive heart failure, we certainly get breathlessness, weight gain, immobility, fatigue. So a lot of the similar symptoms. And so a lot of palliative care is addressing symptoms. The symptoms are often poorly managed because it's not like in your heart when they do an EKG or when the doctor listens to your heart.
Seeing that on the screen.
And he knows you have an arrhythmia, an irregular heartbeat. So then it's one symptom he's managing is what's going on with that arrhythmia. With people who have multiple chronic illnesses or long-lasting chronic illnesses, the symptoms are often poorly managed and can cause a lot of burden, even though they're not a fancy diagnosis. So this, of course, affects both the patient and the caregiver or the family. I think what the literature shows is most effective about palliative care is that it does improve quality of life. It is, and this one I particularly agree with, it helps manage those psychological symptoms like anxiety, depression, fear, fatigue of fear of taking on new issues. It improves symptom distress. It improves functional status, because if you're not feeling worried and stressed and anxious as much as you were, then your mind stops using energy for that and uses energy for things like getting done what you need to do based on your functional status. And people in palliative care usually have longer survivorship. Now, I will say that in hospice, which is a whole different program and a whole different service, but in hospice, we also see people have longer survivorship when they first go into hospice. And so the problem with hospice is that most people, go in like 3 weeks before they're dying. So they don't get the benefit of the long term of the service. So that's really all I'm going to talk about hospice, unless you have questions, because palliative care is really, it is a process of managing both physical and psychosocial symptoms that also affect caregivers, and it requires some input from different people. You would hope that it involves a multidisciplinary team and or a specialist in palliative care. So again, it's associated with these reduced anxiety, reduced hospital admissions, and I keep saying it, benefits do extend to the caregivers and the family. Caregivers particularly, it is supported early on and later. So palliative care is basically provided by a team of doctors, nurses, or other trained people.
Excuse me just a minute.
Francis, did you have a question?
Did we lose her?
She has muted herself. She's good.
Okay. Okay. So palliative care is provided by a team of doctors, nurses, or other specially trained people, and they really work with you. They work with the patient and the family to provide an extra layer of support. And that support, that medical expertise and support, complements your ongoing care. So it doesn't take over any care that you're already receiving. It can be provided to any age person who has a serious or a threatening illness. So there, long ago, when palliative care was first getting started, the notion was that people should get a palliative care consult if they were when they were ever first diagnosed with something like congestive heart failure. And the example is because you don't get over congestive heart failure. It's something that you continue to deal with. And unless you have wonderful management of it and your heart doesn't become more frail, it tends to get worse or progress with time. So this is a service that is trying to help manage the symptoms, reduce the distress and the stress of dealing with the diagnosis, the medical care, and just all of the stress of dealing with that. It is a billable service. So it's billable to Medicaid, and it's billable to Medicare as a Part B service, which would be the same as a doctor's office visit. So you would probably have a copay. So to talk about some Roanoke services, I want to give you what I'm familiar with. I'm just going to say that disclaimer right now. That is the service at the Carilion Center for Healthy Aging, which, as another disclaimer, I worked there for decades and helped start that service. And then I have worked with Good Samaritan for years as a hospice service. Something one of my nurses at the center once, who used to do hospice work, I said, "Which hospice service do you prefer?" And she said, "Well, the service is going to have its unique standards, but there's no bad hospice nurse." And in my experience, that's about true. They're in that service, in that practice, in that care arena, because they care about people who are at the end of life and they want to provide good service. Well, palliative care is a little more proactive and active. It's a little different than that. So I wanted to talk to you about the Good Samaritan Palliative Care Program. Again, not the hospice service. So again, I'll stop right now before I go into two specific services in our area and see if there are any questions.
I have a question.
Okay.
When does one get connected with the care? Is it while one is in the hospital or after one comes home?
It is when one comes home.
So you still leave the hospital, come home, and that person then comes to call or whatever.
And I actually am going to show you how you connect with these two services because they're a little different. But let me also say that while you're in the hospital, you can get a palliative care consult. In other words, one of the physicians you're going to see on a slide will come and make a visit to the bedside and meet with your hospitalist and do a consult. And there is also a palliative care unit at the hospital at Carilion Roanoke Memorial. But again, I'm more outpatient focused, so let me get to how you do that. So at the Center for Healthy Aging, there is a whole team of physicians who are palliative care trained and board certified. And Christy Stewart is the medical director and has worked very, very hard to create a service that where the people work well together, where they offer the service regularly, where they're situated with enough team members to help support them. And in this program, a primary care referral is required. So what you do is you call the center, just like you call them for any appointment you'd want to have there, whether it was a psychiatric appointment, a geriatric assessment appointment, a memory appointment, with all the different things that they offer. You just call the number at 981-7653 and say, I'd like to be set up for a palliative care appointment. And they say, well, who's your primary care doctor? And they might say, Dr. Blaylock. And so they'd call his office and say, your patient's requested this referral. Are you okay with that? Are you willing to make the referral? So they kind of do the paperwork for you at the Center for Healthy Aging. There, they have the clinic. They have clinics every Thursday afternoon, and because palliative care is growing, they are now scheduling some on Tuesday afternoons also. An initial appointment is anywhere between an hour to an hour and a half, and most of the time, what they're doing is they're looking at your medical record, talking to you, examining you, and figuring out what your needs are. And based on that, based on your needs, they're going to then decide whether they should or could offer you a follow-up appointment, or whether they could offer you just the end of this consult. So that's the discussion that the doctor would say, well, based on these symptoms, I'd like to try this treatment and see you back in 2 weeks or 4 weeks and see how you're doing. The follow-up appointments are much shorter, usually about half an hour. And the palliative care specialist physician does communicate with the referral physician. I know with Carilion, it's on the Epic, the medical record. So if your primary care physician is Carilion, the information's right there. And they probably send them a quick Epic note. With other physicians, there is the methodology of faxing it to the primary care office. But again, that's going to be the primary care office that's on your medical record. And you know how people change and fax numbers change. So that's one of those that might need a little follow-up just to make sure the primary care physician received that fax. So that's pretty much the Center for Healthy Aging. I reached out initially to Aubrey Knight. I don't know if you all remember Dr. Knight. He's spoken at our church too, and he and I worked together for so long. But he's all med school right now, pretty much med school, and I think he's still a medical director at an assisted living, I believe. And he gave me the names of these people, and then I called the Center for Healthy Aging and updated it a little bit. So, he's not as much in that world anymore, just like I'm not. But I had heard, and Dr. Knight told me, that the Good Samaritan palliative care service that was relatively new had become a leader in doing a good job in our region. And I'm very comfortable with the Good Sam people. So I was planning to call, and I was at a ribbon cutting for Richfield's new healthcare center. And I've served on their board for years. And this nurse was standing there that said, "Good Sam." "Excuse me, can you talk to me about the palliative care service?" Well, she was wonderful, Chris Connor, and she was there to represent Good Sam. And she had a brochure, she had a card, she could answer a bunch of good questions. And so from there, I started making phone calls to talk to whoever I needed to talk to. I ended up speaking with Gwen Spangler. So she's educated like I am as a doctor of nursing practice, and she is the program director. She is the nurse practitioner who started the program about a year ago, and she makes all the home visits. They are growing and they've added staff, but they do now have a chaplain and a social worker who's also an LCSW, which means that the LCSW means that they're a counselor and that they can provide counseling services and bill Medicare for that. Even though, I think it's a woman, even though this person is part-time. Gwen says the most frequent issues they've been dealing with, again, we're not surprised here, symptom management, as well as care conversations. So a care conversation is bringing resources to the table. So some of it is basic stuff like, do you have a power of attorney? Do you have advanced directives? If it's appropriate, do you have a do not resuscitate? I mean, some people think a do not resuscitate is something they do at the very end of life. I am completely the opposite on that. When our children turned 21, we sat each one of them down at a time, and Brady and I did together and talked to them about what power of attorney and a DNR are, and gave them the option of completing the papers and choosing who they would pick if they were not able to make their own choice. And of course, as families work with 3 children, all their choices were different. Some wanted both of us, some wanted one of us, but they all felt it was an important, no one felt uncomfortable with the conversation. In fact, our oldest, Wyatt, said, "Thank goodness you took care of this before I got out from under you, because I would have never known to do this. And the last thing I want to be hooked up on tubes for the rest of my life." 21-year-old talk. So they help with these care conversations, which sometimes I know in my years of work in outpatient, that sometimes it's the caregiver, the spouse who's hanging on, or the child who's hanging on. And the person who's dealing with all the symptoms and the diagnoses and the appointments is the one who's saying, "I'm tired of doing all of this back and forth. I'm tired. I'm not giving up. I'm just tired. I'm just worn out from all of the care that it requires." So that's where a care conversation is very helpful. One of the most frequent things that Dr. Spangler also offers is all of her visits are home visits. She has tried assisted living, but again, because it was during COVID, it was very awkward. They'd be closed down. They couldn't go in and see people. So almost all of hers are home visits. But in other words, they say they go to where the person's home is, whether that's the assisted living, an apartment where you've retired to an apartment, or whether it's the home that you've lived in, for a long time. But one of the things she does on a home visit is often she finds that people would benefit from some physical therapy to increase their endurance a little bit and reduce their burden and fatigue. And so if they agree to try physical therapy, she makes the referral to the home health agency of the patient's preference. So she said that she thinks they've grown so quickly because of COVID, because everyone was scared to go to the ER, scared to go to the doctor's office, knew they needed help, so they reached out. If it's like in my family, some daughter probably called from out of state and said, "Look, I've looked online and there's a palliative care service, a couple of them in Roanoke. You need to see if they can provide you with some assistance." So they've recently hired another nurse practitioner full-time, and they're also adding in a referral LPN. So here at the Good Samaritan Palliative Care, the patients and families can schedule themselves. It doesn't require a physician referral to enter the service. So I could pick up the phone, make a phone call. They would get back to me within 24 hours and schedule me. And then they would reach out to, they would, ask questions and get some information about you to see if they thought you were appropriate for possibly appropriate. And then they would reach out to your primary care. So they want to make sure, which is what you want, anyone you're seeing as an additional provider, you want to make sure that they are in the loop, that they're keeping your primary care or your specialist. I mean, if you've got cancer, it'd probably be your oncologist, that they're keeping them in the loop of helping you feel better with their symptom management, reducing symptom burden. So at Good Samaritan Palliative Care, they do home visits monthly or as needed. She said real often people start declining and she'll see them every 2 weeks. But then she's had some people that she's seen once or twice and they're like stable. And so they say, no, it's okay. I'm okay now. I know how to call you if I need you. She is available for these home visits 9 to 5, Monday through Friday. But they do have an on-call service with clinical people available in the on-call service, which is 24/7. And this is the number that you use to call for Good Sam referral. If you leave a message, I am assured that you can expect a return call within 24 hours. Do you have any questions about the services now?
So I'm still confused about one aspect.
Okay.
If I weren't a member of Second Pres, I wouldn't know about this. In other words, my question, or more directly, are physicians or social workers in their offices or in the hospital handing you a card or a slip of paper recommending that you might contact this? Is this someone you have to know about because you're a member of Second Pres and therefore we've heard you speak? I don't understand how one gets connected.
So basically in the hospital, there should be someone who's willing to say, perhaps consider palliative. But again, palliative care is not, an office. So it's
Understand that.
It's a service.
Right.
So, and a lot of primary care physicians and internists are capable and willing of having the conversation of do I or do I not want palliative care? Or even if you want palliative care, I can manage it for you as your primary care physician. These are the things we should discuss, So physicians can own that. So I don't mean to say it has to be a special service, but it takes a lot of time. It involves a lot of conversation. And because of that, it's not very billable. So if you've got a busy practice where you're seeing someone every 30 minutes or every whatever, then it's very hard to have the time to have the conversation that considering palliative care deserves. So it's not a secret. It's not a Second Pres secret, but it's the kind of thing that people don't know they need until someone kind of says, have you ever thought about palliative care? And by then it's probably too late. It was probably their neighbor or the bridge buddy who said, have you ever thought about palliative care? So, those who are in the medical world are always dealing with medications and labs and diagnoses and trying to reduce people's pain and stress. And so looking at 5 different diagnoses or at a chronic diagnosis that's been going on for some time is not an easy fix. It's not an easy answer. It's not a quick answer. So most physicians, once you have expressed some interest, a lot of physicians don't want to be the one to bring it up. But if you said, like I said to my father, who's 92, to his doctor when he was not doing well, I said, are we at the point where I need to discuss hospice with you? And he said, no, I don't think so. He gave me a couple reasons why. I said, well, I know there's not a palliative care service here, but is there anything different that would be done if palliative care was provided? And so he was he's a geriatrician, so I'm lucky, okay? So he was very capable in assuring me that where we changed this medicine, where we've taken him off this medicine, where we chosen not to do this therapy again, or because basically he'd exhausted the therapy and they couldn't get him any better, that those were things that palliative care would have done. So, I feel like that's held true. He has responded as a palliative care physician for my dad, which is great. It's such a blessing to have someone in your care team who is not scared of talking about things that are real. So anyway, I came up with did that help you, Carol?
I think so.
Okay.
Can I ask
And
a
Bill's
question?
got his hand up, Martha.
Okay. Hey, Bill.
Yeah, as a caregiver for a number of years, one thing I learned that you have to do is adapt, adapt, adapt. And if you have all of these people, whether it's home health, palliative care, or hospice, you got to do something different, but you don't know what next to do. So I think that can be very helpful in helping you to adapt to the situation.
Excellent. I couldn't agree more. And I think that's where you sometimes find is when someone new comes in, like the examples you gave, they come in with a little fresh breath, a little fresh look, and things that you think, well, I wonder why we hadn't tried that before. It's because people are doing the best they can, but a little fresh look is never a harmful thing unless they're going to recommend, surgery and go in here for another opinion and things like that, which that's maybe what you want, but that's probably not what you're going to have in palliative care. But palliative care does treat. They don't deny treatment. So a lot of the things that you would have done for you when you were in a regular physician's care, palliative care may also recommend, because they're controlling symptoms, and sometimes treatment is how you control symptoms. So I've got three quick, I might have just done two quick case studies. I thought, I don't know if this is helpful, but they're real life, so I thought it might be helpful. So one is a 70-year-old man, 70-something, who had a cardiac transplant 15 years ago. He's an ex, I don't know, Navy SEAL or some armed service, dude. And he has now, he's with 15 years post-transplant, he's got severe congestive heart failure. So he's got a lot of shortness of breath. He's got an indwelling Foley catheter draining his bladder. He has some pain, but again, he's stoic, so he doesn't want to admit or talk about the pain. So when palliative first started visiting him, the first thing they did is put a nebulizer in the house for his shortness of breath. Then they made a home health consult for a specialist in lymphedema therapy. So that's where you've got fluid that's kind of stayed. I don't know if any of you remember, like when my grandmother had a mastectomy, she developed this giant fluid that hung down under her arm on the side where the breast was removed. And it was uncomfortable. And so now there are lymphedema therapists who can get rid of that fluid before it's stayed so long that you can't get rid of it. So I thought that was wonderful. This gentleman was very tired of the emergency room because with shortness of breath, what are they going to do? They're going to take you to the emergency room unless you've got one of those things signed up that says, don't take me to the emergency room, plastered on your refrigerator. So he was tired of the emergency room, and after 4 months in palliative care, he wanted to enter hospice. During that time, she made weekly visits to him. This was a home visit case. So the weekly visits were during this time of crisis. So every effort to try to keep him out of the ER because he was tired of it was being made. And the second one is a 105-year-old female who, she's not depressed, but she's ready to go. She's ready to meet her maker, and she doesn't want any treatment. She certainly doesn't want to go to the hospital. She's lived in her home alone until 6 months ago. She wants to get to hospice. I mean, that's her goal. I want to be in hospice care so I don't have to leave my house, so no one can come and pick me up and take me to the emergency room. And so at 104 and a half, she ended up moving in with some family, and they helped her find this palliative care service. And she is receiving monthly visits. And I believe the purpose of the monthly visits is to see if she's declined to the point that she's eligible for hospice, since that is what she has said she wants. So the nurse practitioner goes out there, does an evaluation, talks to her, and tries to help with that. Do you have any questions about the case studies? Okay, so in summary, palliative care is provided at any stage of illness along the way. It is certainly can provide treatments that are meant to cure. Let me get to that page. That doesn't look right. Yep, along with treatments that are meant to cure. So palliative care, again, at any stage of illness. Palliative care is specialized medical care for people living with serious illness. The focus is on providing relief from symptoms and the burden and stress of a serious illness. The goal is to improve the quality of life for both the patient and the family. So palliative care is nothing to be scared of if you don't mind having an extra service being provided to you. And in our valley, the two programs that I was familiar with and able to get in contact to find out more about, they're quite different, because at the Carilion Center for Healthy Aging, you go to them. It's an outpatient visit. You go to the clinic and you see the team. And if they need to get their social worker who's always there, they get them. Whereas with the Good Samaritan palliative care, they come to you. They come to the home, and or one of them comes to the home. The nurse practitioner, Dr. Spangler, is always the first visit and does most of the visits, is the way it's working out right now. So, and both of them pretty much see people monthly if it's needed and if it's desired. You know, some people, when you tell them this is the lay of the land, then they are okay. It's like, I just needed to hear it from someone who hadn't heard my same aches and pains for so long. I just needed to hear it from someone with fresh ears. I had someone say that to me one time, with fresh ears. And so they don't need to be followed up, or they don't need an appointment right now for follow-up. They like having that option, knowing if I need it, you're there. Now, I hope you did see that the Center for Healthy Aging is scheduling at least 4 weeks out, and she said maybe you should think 6 weeks out. But they have added this Tuesday clinic. I didn't get a time on how frequently the Good Samaritan service is, but my sense, because she's just hired a new nurse practitioner, is that they can probably get to you pretty promptly. I mean, I would guess in a week or 2 weeks. So that's amazing, as you know, in current healthcare. So I hope this information has been helpful to you. I'm happy to answer more questions, or let you all just talk, and I'll just sit here and listen, whatever sounds good to you.
Do you want to keep it on record, Nancy, or go ahead and stop the recording and have a discussion?
I have one question that I'll pose, and then if we want to stop recording and engage more conversation, that's fine. I think Martha's aware, I've shared this with her. You know, my congregation in South Carolina was predominantly retirees, and this concept was so new to them. Say some more, Martha, about the interface or balance between palliative care and hospice care. I think so many people think that palliative care is just hospice with another name, and there were the same reluctance to seek those services, seek hospice services, applies to palliative care services. But if it's my understanding that anyone, and correct me if I'm wrong, who's diagnosed with a chronic condition where symptom management would be needed, palliative care is appropriate in that situation at whatever age. But are there other ways to help people see beyond palliative care just being another word for hospice care?
Well, hospice care requires a physician to sign a form that says you have 6 months or less of expected life. Now, in hospice care, that can be renewed. I mean, a lot of people in hospice care stay on hospice for a year or two or go off hospice. I've had quite a few patients go off hospice. They came in, they offered the services that brought relief, brought comfort, brought a different care plan, and the family got it under management, or the patient did, and they were discharged and were happy to be discharged and went on for quite a while. So it's, people are at the end of life for hospice care. The problem with that is that people put it off because no one wants to think they're at the end of life, or your wife doesn't want you to, or your husband, or your child. So that's part of the reason for hospice. And my mother was dying of lung cancer, and I begged to have hospice come in. I mean, she was so short of breath with oxygen. And I said, it'll be a comfort, Mom. And we got hospice in. Finally, I think it was the last. I have a sister with better memory, but it was less than 2 weeks. It might have been 5 days. It was just, they could have been such a comfort to her and to my dad, who was exhausted from 2 years of caregiving. So hospice is that bailiwick, whereas palliative care is managing a medical illness. So it's a severe medical illness with a symptom burden, symptom load, lots of things making you feel bad. And some of the symptoms are nondescript, like
Can go under palliative care if they are expected to get well, if they're going to be sick.
yes, palliative care is available if they're expected, if they have had, it's chronic though. You've got to have a medical illness that's either very severe, and that would mean a way of saying, I'm not getting these symptoms managed, so I need some help. Let's try palliative care. Or it could be the case of, if I live through the treatment, I'll probably survive and be okay. But while I'm living through the treatment, I'd like to have palliative care involved. So palliative care is a specialized team. And Nancy, that's where it's different than it was 15 years ago. I mean, our first palliative care physician in Roanoke, there was no board for him to sit for. There was no board certification in palliative care. This was someone who said, I'm going to go and take this seminar. I'm going to do this, I'm going to take an extra class, who took their learning on themselves and their compassionate care on themselves. Now it's in the school. It's out there for a fellowship in palliative care. We have fellows rotate through at the Center for Healthy Aging. And actually, I should probably point that out as a difference between the two services I've chosen to highlight. If you go to the Center for Healthy Aging, we've got VTC School of Medicine. So we've got the med school there with all of our residents and fellows. So when that physician, those 5 physicians I listed to you, comes in to see you, they'll have a fellow or resident with them, almost assuredly. Whereas the nurse practitioner, I mean, occasionally, like I used to, she'll take on someone who needs some clinical experience, who's in nurse practitioner school, for a couple of months or 6 months, but she's not going to have a bevy of residents and fellows following her around. At least I think that's accurate. Let me just say I'm pretty sure that's accurate. So palliative care is, you're overwhelmed with ER visits, doctor's visits, pills, managing your symptoms, not feeling good while doing all of this, not feeling better while doing all of this. That's when palliative care can say, what can we change here so you feel better? To me, that's one question I like to say to people. If a specialist came in here and said, if we change this and this, I think you'll feel better because you told me that your main complaint right now is whatever. And to me, that's like, let's try it. I mean, it's not gonna hurt anything to try.
Bill has a question.
Okay.
Yes, I didn't know. It sounded like we were wrapping things up, had to leave for a few minutes. One comment, right before I came to get on this program, I checked my email, and for medical grand rounds at Caribbean on Friday, it's on palliative care. Now, the other thing is back in October, they had a grand rounds conference on palliative care, and following, well, during that conference, I took a little notes because I have to sign up for educational credit. And it dawned on me several things. So I fired off a note to Preacher George, and I'm going to read you what I told him. I said, the purpose of palliative care is to improve the quality of life and promote relief of suffering, all symptoms, including stress. Palliative care also improves the quality of life and relieves stress for family members. And the speaker showed a pie-shaped graph where the following 4 things were represented as far as symptoms: physical, emotional, social, and spiritual. And I wrote to George, it dawned on me that knowing this kind of information would really allow congregants to offer up meaningful prayers. Otherwise, we can only pray for God to comfort the patient and the family, which is analogous to saying, thy will be done. My interpretation of having one's name placed on the prayer list involves losing some of one's privacy in order to have our brothers and sisters in Christ to intercede on our behalf. And I was just asking him if we should publicize that more. And he wrote back and he said different churches, how the congregation reacts are different. When he was in Mississippi, which was a deep South congregation, he said, basically everybody shared everything with everybody, but he said he has found greater resistance to that approach at Second. And then he, brought up the fact that we Scotch Irish kind of keep things close to the chest. But anyway, he did agree that the more people you share with, the more people can provide help to you and your family. And you basically, when you let somebody know, you sort of summon that cloud of witnesses to appear and do their work.
Thank you, Dr. Blaylock.
And Bill, thank you for bringing in the spiritual component. That is interesting to see that it's clinically a part of palliative care and hospice care. And the faith community does have a role to play.
Well, and these services, like the service at Good Sam, has a chaplain. I mean, that says right there, it's a priority. But probably at the center, you get more questions like, how is your faith community supporting you? What have you asked them? How have you reached out to them, or have they reached out to you? It's a more typical question from there.
Deborah, maybe this is a good point to stop the recording.